All right. Good morning, everyone. I think we're going to get started here. My name is Gretchen Kunze. I'm a pharmacist at Amplify Health by Gunderson in La Crosse. Welcome and thank you for joining us. This session is designed to engage pharmacy students, pharmacy technicians, and pharmacists, especially those that are involved in pharmacy education and precepting. Today's session will focus on the entrustment scale and its growing role in pharmacy education. You'll learn how the scale was developed and how it's being used to assess learner readiness. We'll walk through each tier of the scale and discuss when it's appropriate to select each level. You'll also evaluate real-world student scenarios across various settings and skill levels to determine the appropriate tier of entrustment. We're pleased to welcome today's presenters, Sarah Peppard, Stacy Reed, and Melissa Thiesfeld. Melissa Thiesfeld is the Assistant Dean for Clinical Affairs and Professor of Pharmacy Practice at Concordia University, Wisconsin, School of Pharmacy. A former clinical pharmacy manager and past PSW president, she now leads experiential education at CUW SOP, while mentoring students and residents, and currently serves on the board of Wisconsin Pharmacy Foundation. Sarah Peppard is a board-certified critical care pharmacist and pharmacotherapy specialist who serves as a professor of pharmacy practice and assistant director of experiential education at Concordia University, Wisconsin School of Pharmacy. She also practices as a critical care pharmacist in the medical intensive care unit at Froedtert Hospital. Rounding out the speakers in today's presentation is Stacy Reed. Stacy is the Assistant Dean of Experiential Education and Clinical Assistant Professor at the Medical College of Wisconsin School of Pharmacy. A Drake University graduate and residency-trained pharmacist, she brings a strong background in clinical practice and experiential learning, serving as a vital connector between students, preceptors, and pharmacy practice sites. Excuse me. Full speaker bios are available in the conference app. Please join me in giving them a warm welcome.
Thank you, Gretchen, and thanks to all of you for being here today. I know it's bright and early in the morning and it's a little dim in here, but I promise we will put you to work a little bit and get you talking. We will have you doing some work in groups. I promise it will be fun. I know everyone hates group work. We are used to that in the classroom, but I promise it will be fun. So if you want to move around a little bit later, that's totally fine. We are excited to have both of the experiential education departments from the schools of pharmacy in Milwaukee working together on this presentation. We work together a lot on the experiential things that our schools do together. We know that a lot of our sites overlap, so this is a fun opportunity for our programs to work collaboratively and share some information about entrustment and how many of you will be assessing our students from both of the schools of pharmacy. None of us have any financial disclosures, so this will be a quick slide. One of the things that we'll spend some time talking about today is providing you with a little bit of history and context about the concept of entrustment and how we got to this point, and how entrustment is really built into experiential education. But what we really want to spend the majority of our time doing today is giving you the opportunity to practice applying this concept of entrustment and thinking about how you would apply entrustment and give learners this skill or give learners in your ability to or impart trust onto learners. So trust is a pretty heavy word, right? Especially at this time of year when we're in the summertime. Those of you who are working at academic medical centers in particular, you have a lot of new medical residents, you have new pharmacy residents. So this time of year is pretty tricky. Everyone is new. And so thinking about giving anyone trust to do anything sounds a little tricky. We might not give anyone trust to do anything. But eventually, we have to give our learners the ability to do things with our patients. I think there are some interesting parallels with our speaker, our keynote speaker from yesterday. Those of you who were here yesterday and listened to our keynote speaker who talked about the standards of care practice model. We all want to eventually practice at the top of our license, right? And to do that, we have to give learners opportunities to practice that. And eventually, that comes during their rotations, and we have to give them some ability to have that independence and have that authority to do those skills independently and yet give them feedback and give them some confidence in doing those skills. Many of you have been precepting for a long time. Many of you have gotten really familiar with the evaluation forms that you've been using for lots and lots of years with the schools of pharmacy that you've been precepting for. And so now at this point in the year, I know some of you have gotten a chance to evaluate students using new forms. And all of a sudden these forms look a little bit different. And that can be a little bit frustrating. So hopefully this presentation will give you a little bit of that context and will share with you some of the rationale for why things look a little bit different and make you a little bit more comfortable with these changes. None of us as presenters today started our careers in academia. In pharmacy, we're really used to all these abbreviations and the alphabet soup that comes within our profession. And we didn't start out being super familiar with these abbreviations either. So we wanted to provide a little bit of context for all of you. I think probably everyone in the room is familiar with IPPEs and APPEs, right? The introductory pharmacy practice experiences are those rotations for our early learners that happen early in the curriculum, and then advanced pharmacy practice experiences happen during the final year of a curriculum. So those are probably the easy ones for today. My guess is all of the people in this room are also familiar with the ACPE, the Accreditation Council for Pharmacy Education. Those are the people who give you your CE credit for your pharmacist license. But that group is also the group that accredits schools of pharmacy. AACP is the national organization for all of the schools and colleges of pharmacy throughout the United States. So they are a national group that all of the schools of pharmacy are part of. And then the other abbreviation that we'll use a lot today is EPA. Those are Entrustable Professional Activities. And in a couple of slides, we'll talk a little bit more in detail today, but you'll see these abbreviations used throughout our presentation today. So we're not going to make you experts in pharmacy education today, but those of you who went to pharmacy school probably didn't spend a lot of time thinking about all of the things that went on behind the scenes. You went to class, you studied, you took your exams, you went to lab, you did your OSCEs, but you probably didn't spend a lot of time thinking about all the design behind the scenes that went into making sure you got a good education. Behind the scenes, though, there were people who were designing educational objectives, educational outcomes, and learning outcomes, and all of the learning objectives for all the lectures that you sat through while you were in pharmacy school. Those educational outcomes come from ACPE, and educational outcomes, sometimes also called curricular outcomes, are what all learners, all students are expected to be able to do at the end of a pharmacy school program. They are the knowledge, skills, and attitudes that we want all students, all learners to have when they finish pharmacy school. We want them to be able to demonstrate those knowledge, skills, and attitudes in any practice setting, no matter where they end up going after pharmacy school, no matter which pharmacy school they go to. So those are very global educational outcomes that all schools of pharmacy are expected to be able to adapt their programs to deliver. On a related note, entrustable professional activities are defined professional tasks. They are designed to take those educational outcomes and turn those educational outcomes into everyday practice activities that pharmacists are performing. So we're going to talk a little bit in a few minutes about what those look like. But I want you to just kind of keep in mind educational outcomes are like broad knowledge, skills, and attitudes, but entrustable professional activities are more discrete tasks that pharmacists are doing on a daily basis. If you pull up the slides in your app, you'll be able to see some examples of the educational outcomes that ACPE has outlined. And you can see here, these are really good examples of some of the really broad terminology that ACPE uses for these educational outcomes. So scientific thinking is a really good example of knowledge. We want pharmacy school graduates to have knowledge, foundational knowledge of medications and pharmacy practice. Communication is a good example of skills. We want pharmacy students to be able to communicate, actively engage, listen, and communicate when they finish pharmacy school. Leadership and professionalism are good examples of attitudes. Some other examples that ACPE puts out there for educational outcomes: problem solving, which includes critical thinking, person-centered care, interprofessional collaboration. So there's 12 different educational outcomes, again, that all schools of pharmacy have as their educational outcomes. One of the other things that's available to you in the app is a handout that we've provided. It depicts all of the educational outcomes for you. So if you want a little bit more detail, you can see all of the educational outcomes. We don't need you to memorize them by any means, but you'll be able to see all of the educational outcomes, and we've actually provided kind of a map for you, and it provides the educational outcomes and it overlays the entrustable professional activities, and it aligns them with the pharmacist patient care process. So you can see how everything kind of aligns in a nice little map. In 2022, AACP, again, that national organization for all of the colleges of pharmacy, provided an update to the curricular outcomes and the entrustable professional activities for schools of pharmacy. So that update is just a couple of years old, but the most recent update that had been made to those curricular outcomes had been made in 2013. So that had been, 10 years previously. And in that 10-year span, a lot of changes had occurred. There had been a lot of expansion in the roles of pharmacists. There had been a lot of expansion in the scope of what pharmacy practice looked like. If you think about in 2022, that is a post-COVID role of a pharmacist. So there had been a lot of change in our country. There had been a lot more awareness of health equity, a lot more focus on social justice issues in this country. There had been significant updates to interprofessional competency. There's a lot more emphasis on interprofessional communication and interprofessional education. So it was a really important time, and I think a really appropriate time to make updates to these educational objectives. There's also a lot more emphasis on digital health. There's a lot more technology that we have available to us in health education. So 2022 was kind of a perfect time to make all of these updates. And so AACP took this opportunity to update the educational outcomes, update the entrustable professional activities, and kind of merged them all into a single document. These are some examples of what the revised entrustable professional activities look like. And again, if you pull up that handout that's available to you in the app, you'll be able to see more detail. There are 13 total entrustable professional activities now. This is just a sampling of 7 of them. And on the surface, again, these seem like pretty simple and trustable professional activities. These are things that the pharmacists in the audience are doing on a day-to-day basis. But when you dive into them in a little bit more detail, they really are and can be pretty complex activities. Even when you look at the first one, contribute to patient specific medication related expertise as part of an interprofessional care team. Okay, yeah, we do that, right? But it's not just quite as simple as that, right? Yeah, we're part of an interprofessional care team, but that includes providing recommendations. It includes providing drug information. We're monitoring medications. We're adjusting medications. All of those things are part of that single entrustable professional activity. Even when you look at fulfilling a medication order, that includes making all of the calculations necessary to fulfill a medication order, doing drug utilization review. In an outpatient pharmacy setting, you're adjudicating claims, you're doing compounding, you're evaluating patient assistance programs, you're administering immunizations and injectable medications. So I think, again, it's important to recognize that these entrustable professional activities happen in any pharmacy setting. They're happening in hospital settings, they're happening in community pharmacy settings, ambulatory care settings. No matter where pharmacy students are practicing, these entrustable professional activities have to be applicable. And these entrustable professional activities incorporate multiple educational objectives. It's not just a single educational objective that students are incorporating. So I think, again, as you look at that handout we provided for you, it's not just one educational objective that students are using. They're incorporating many educational objectives to complete a single entrustable professional activity. Entrustable professional activities are just part of the story, right? Now we have to assess how students are doing when we are giving them the ability to complete these entrustable professional activities. So this scale gives us some terminology and gives us an ability to assess how they are doing when we want to evaluate how they're performing and when they're carrying out these different skills. So with this scale, we really want to focus on the terminology. You'll notice that this is a scale that has a lot of description to it. So I realize it may be a little challenging to read from up here. So please feel free to focus on it in the app. But we really want you to focus on the terminology. This isn't a numeric scale where students are given a score. We want you to focus on the terminology. Learners come to us with all different levels of experience. Some of our students come to us and they have worked for a long time in a pharmacy setting. Some of our students come to us with no work experience. Some have different backgrounds. Some have come to us with lots of different skills. So not all of our students will come to us and be able to have the same level of entrustability. So their ability to execute on an entrustable professional activity will vary. So this scale allows you as preceptors to give them different levels of entrustment. So when you take a look at this scale, at the far left-hand side is observe only. This is for a learner who isn't ready to perform independently. This is a learner who isn't entrusted to perform a scale independently, where you as a preceptor are performing the scale and the learner is observing you. Under direct supervision, the learner is entrusted to perform a skill, but you as the preceptor are still there in order to provide immediate feedback. Under reactive supervision, the learner again is entrusted to perform the skill and you are still available, but the learner is given a little bit more freedom to perform the skill. Your help is available and may be required, but you're giving the learner a little bit more freedom and you trust the learner a little bit more that they know when to ask for your help and ask for your feedback. And then all the way up, I won't read them all to you. When we get all the way up to general direction, that's really when you trust the learner fully to perform their skills independently. And the learner can really be responsible for executing the different skills, and you trust them to be independent. I think this also aligns really nicely with the ASHP precepting model. When you think about observe only, that's a really nice alignment with modeling. And then direct supervision aligns nicely with coaching, and then reactive and intermittent supervision aligns nicely with facilitating. So I know that many of you who are familiar with resident supervision are also very familiar with that ASHP scale. So I think that's nice alignment that you can think about there. We provided this as a guide as well, although, as I mentioned earlier, not every student will come to us. So, not every IPI student is automatically going to be in the observe only stage. There will be some IPI students and some activities where IPI students can be allowed to have a little bit more freedom and be able to have direct supervision. I think this graphic can potentially be a little misleading, and it implies that there's this linear progression through the scale. And that may be true for some learners, but there may be times where learners can jump ahead a little bit. One of the important things that I want you to take away from this scale is the fact that the goal for students when they graduate from pharmacy school isn't to get them all the way to general direction by the time they graduate from pharmacy school. When students finish pharmacy school, the goal is to have them at reactive supervision. When students finish pharmacy school, the goal isn't to have them being completely independent and ready to be totally practicing independently at the time that they finish pharmacy school. APPI students are meant to be at reactive supervision at the completion of a PharmD program. They will still need additional training and additional growth after they finish pharmacy school. So, as I mentioned at the beginning, some of you probably have seen some changes in assessment forms for APPI students in particular, or IPI students. ACPE standards have changed. There are new ACPE standards for all schools of pharmacy that went into effect starting July 1st, that all schools of pharmacy are now in the process of implementing. And in particular, standard 2 that relates to the curriculum talks about educational outcomes and activities, and it incorporates all of these concepts, including educational outcomes and entrustable professional activities. So all schools of pharmacy are incorporating these concepts in a little bit different form, and we'll talk about those a little bit later in our presentation. The nice thing about these is that while these are guiding principles, all schools of pharmacy are able to incorporate them in a way that works with their program. So in addition to, one of the things is incorporating entrustable professional activities and the assessment of these achievements of the assessment of student achievement of these outcomes. Just making sure I covered everything I wanted. So hopefully this Slido question works. This is our first test of things. So in your app, you should have a Slido question that pops up. So this will be our first quick quiz for you. So in your app, you should have a polling question, and you're welcome to complete it there. So true or false, at the completion of pharmacy school, all graduates can be entrusted to independently decide what daily pharmacy tasks need to be performed and can supervise the activities of others. Is it popping up for you? Oh, bummer. All right, well, I guess we'll wing it. All right, Gillard gets a gold star for the day. So the answer to this question is false. So, um, as I mentioned earlier, the goal isn't to have all of our graduates um, all the way to the end of this entrustment scale. We want them to be at reactive supervision. So that means they can perform the task without direct supervision, but they may need to ask for assistance. So with that, I'm going to turn things over to Sarah, and we're going to talk a little bit about what some of the assessment forms look like that you may be seeing in your practices.
All right. Thank you, Melissa. Good morning, everyone. As Melissa just covered, the ACPE Standards 2025 and EPAs and how they relate to some of the assessment forms, we're going to now do a little bit of practice. How do we implement this? How do we assess entrustability? How do we apply this scale to our learners? We're going to start by taking a step back from pharmacy and talk about EPAs in our everyday life. How many parents are there in the crowd? Okay, a lot of parents. This is something we do whether you're a parent, whether you're working with learners in a pharmacy setting, in a volunteer setting, wherever you may be. Eventually, we want our students and our children to be functional adults, functional pharmacists, doing things independently and doing things even better than we did, right? That's the ultimate goal. So I'm a parent of a preteen. I've got a 12-year-old at home, and we are working on getting her to build a little bit of independence. She would like to cook more and be more active in the kitchen. So we think about this entrustment in that setting quite a bit. So her goal is she wants to be able to cook independently. So in the example I have on the slide, she's helped intermittently here or there while I'm kind of leading the meal plan. Demonstrates the ability to read and follow directions, able to turn on and off the gas range, which is an important element of cooking. But she is a little bit nervous about draining noodles, about taking that hot boiling pot of water, carrying it over to the sink and dumping it. So that's kind of where she's at right now. So if you are me and you have my daughter, you're working with her in the kitchen, what kind of level of entrustment are you willing to give to her to make her own mac and cheese? So the first level would be observe only, where you're doing it. She's watching you. She's not interacting at all. Direct supervision. Could she make it with you in the kitchen, watching her, making sure she's doing all those steps appropriately and intervening right there? You're right there next to her. Could it be reactive supervision, where maybe I'm sitting on the couch watching TV and she's in the kitchen making the mac and cheese, but can call out to me and say, hey, I'm at this step, I need help. Or intermittent supervision, where I might be out in the yard, I'm reachable, but not right there. She needs to stop what she's doing, make some intentional movement to get me to help her. Or am I at the grocery store and not even in the house, and she's doing this independently when we're not there? So this is the audience participation piece. You guys can take I'll give you like 30 seconds to kind of discuss how much entrustment would you give my 11-year-old daughter? All right, what did you guys come up with? You can go ahead and shout it out. Reactive, okay. Direct, okay. Yeah, so you can tell I gave you 3 bullet points about my daughter and where she's at in her learning. Obviously, when you're working with your own children or working with your own learners, you get to know them on a different level and have a sense for where they might fit. But yeah, I agree. For making mac and cheese, she's probably good to do it. She can, I need to kind of be there if she has trouble lifting that heavy pot or is afraid that steaming bellow, all the steam coming out of that boiling noodles, that intimidates her a little bit, to make sure she gets through that step okay, and then she's probably fine. Now, how would that change if she's like, Mom, I'm going to make chicken fajitas for dinner tonight? How does that level of entrustment change? The task is a little bit more complex, right? It involves some knife skills. There's raw meat involved. There's more going on that task is trickier. So where do you think that entrustment falls now? Yeah, so direct supervision, I need to be right there. There might be things where I have to say, okay, I'm going to show you how to do this, and then you demonstrate to me. So it's going to change. So as Melissa kind of pointed out, it's a continuum, but it's not this like linear graph. It's gonna your level of entrustment is going to change based on the complexity of the patient scenario of the situation. It's also going to change based on the learner. It's also going to change based on the environment. So can she do that in a home environment where there's where she's cooking for one family? Am I going to throw her into a situation where it's a busy restaurant and there's multiple things, multiple ranges, multiple things going on? That's a very different environment than doing it in one kind of protected setting. So it's not a continuum. It's not this linear relationship. It's going to have branches. It's going to have backflow. It's going to depend on what else is going on. So with that, we're going to apply in the example on the slide here. So which of the following best describes a setting where direct observation is the most appropriate level of entrustment? Would it be the first one, a 10-year-old using an iron for the first time, a 16-year-old who has just passed their behind-the-wheel driver's test, a 14-year-old who is asked to mow the lawn for the second time, or a 9-year-old tasked with making toast? Which one do you think best fits with direct observation? Would it be A, B, C, or D? You guys can kind of talk and shout out your answers since we don't have Slido. All right, what did you guys come up with? C? Okay. Okay, so the 14-year-old that has mowed the lawn once, but you want to directly, you want them to observe you mowing the lawn for the second time? Okay. Any other ideas or thoughts? A? That's where my mind went. I don't know. Maybe you're very anal retentive about your lawn. I know that's how my dad was. Like you had to mow it a certain way. The second time, the lines have to go the other way. So I get that. We all have our OCD tendencies. But yeah, I had selected A for this one. Answer B would not be ideal, as this person has taken a test and demonstrated their ability to drive in a supervised setting. And so they should be at the level of general direction at this point. A 14-year-old who's been asked to mow the lawn for the second time, so maybe they've mowed it once before, they've demonstrated that they can do it. If they get stuck, maybe you want to be around if they've got questions or have a hard time with some element of it, or they had to stop and can't get the mower restarted. You need to be kind of in the vicinity. And a 9-year-old making toast, kind of a low risk activity. They could probably do that with you, under reactive or intermittent supervision in that situation. All right, so let's now apply this to pharmacy settings. So let's take one of the EPAs. I have one of the EPAs listed there for you on the slide. So collect information necessary to identify a patient's medication-related problems and health-related needs. So this EPA can encompass a lot of different tasks, and some of those example tasks are listed for you on the right side of the table. So collecting a medication history from a patient or a caregiver, collecting a patient's experience with the medication, collecting information related to barriers or a patient's medications experience, collecting data from a medication record. Can they pull together medication information from multiple sources to kind of come up with a list, to compile that information? So this EPA. And on the next slide, we kind of talk through the different levels of entrustment and how that might look different depending on the level of learner, right? So collecting a medication history for a for a P1 student on the first day of IPI rotation, direct instruction might, or direct observation might be appropriate, or observe only might be appropriate, where they are watching. So we know you've learned how to do this in school. You've done it in a simulated environment, but this is how we do it in this setting. This is how we do it at this community site or this hospital site. Here's how we do it. Watch me do this once. Maybe then on day 2 or 3, they are doing it independently, or you're there in the room. Maybe not, maybe by the end of the week, then you're letting them do that. They're doing they're on their own. You're there for consult if something comes up or if they have a challenging situation, but they're essentially functioning independently. For an APPE student, by the time they get to APPEs, they should be able to do a medication history, and so that observe only is likely not going to be appropriate at that APPE level. And we would maybe under direct supervision, maybe that first day of rotation, again, because it might be a new site to them, a new workflow, a new practice model that they haven't experienced before. Maybe you're watching them obtain that medication history and kind of helping coach, being right there if things come up or if they don't know exactly how to document something. But they should be able to do that skill. And then kind of going on, and that level of entrustment is going to change after you've observed them and participate in that activity in different scenarios with different degrees of patient complexity as they progress through their APPE rotation. All right, so with that in mind, let's practice again. So which of the following best describes a setting where direct observation is the most appropriate level of entrustment? Would it be a Block 3 APPE student completing a new medication education on lisinopril? B, a first-year IPI student on first rotation performing a quality assurance check on a technician-filled medication for the first time? C, an immunization certified second-year IPI student assessing patient eligibility for CDC recommended immunizations? Or D, Block 7 APPE student providing a written response to a drug information question? So you guys can take a minute to kind of discuss, what do you think, which one of those would be most appropriate where direct observation level of entrustment is needed? Okay, you can go ahead and shout it out when you have a B. That is what I came up with as well. So answers A, C, and D are not best given the level of learner and the complexity with the task they are assigned. Although the level of entrustability would ultimately depend on the student's ability to demonstrate knowledge and skills, they should at least be at the level of direct supervision based on where they're at in their learning. All right, good job. So I'm going to briefly transition into measuring trust, and we'll get more opportunities to practice with this entrustment scale. But we thought it would be a good opportunity to share some examples of how this entrustment scale has been integrated in into some of the evaluation forms you see as preceptors. So as Melissa mentioned, every school of pharmacy is implementing this and is required to have entrustment language within their assessment tools. But how that looks from school to school is going to differ a little bit. So here is one example where the scale we've used in the past is still there, but that entrustment language has been incorporated. So at the level where you're evaluating somebody, if they are observe only at the point of evaluation, that is significantly below expectations, and we sort of adjust how we assign ultimate grades based on the level of the learner. So obviously for an APPE student, our expectations are higher than for a first year IPI student. So what we do on our end changes. We want you guys to use the scale objectively as you work through different tasks and activities that you're evaluating the learner on. With that, I'm going to hand things over to Stacy Reed. She is going to go through another example of how entrustment scale is applied in the assessment forms, and then also some additional cases in practice for you guys.
So, a little bit different to how Concordia does their grading at MCW, because we are the competency based curriculum, we utilize just the entrustment scale to evaluate our students. We don't tie the entrustment scale to any scores or grades or anything like that, but rather we look at a progression of our students across their IPPEs and APPEs. Um, when we utilize the entrustment scale, and you may have seen this in some of our evaluations, we utilize the first 3 levels for our IPPEs, recognizing that they might not really be all the way up to that general direction. And similarly with APPEs, we utilize the first 4, knowing that general direction is not really where we expect them to be achieving by the time they graduate. So, if you're not sick of audience participation yet, we're going to do even more. So, we're going to go through a bunch of cases with different learners, different situations, and describe those. And then on the next slide after that, you will be able to evaluate their entrustment scale for a given EPA. So, the first one we have is JL, who is a first year IPPE student on their very first week of their community IPPE. And they are going to administer a flu shot to their patient. So they have been able to evaluate if there's any contraindications with their preceptor kind of reviewing that after them. They're able to counsel the patient regarding the immunization with the preceptor standing next to them. And then they're able to administer that immunization with minimal assistance doing that. So we're looking at the EPA of assessing the collected information to determine a patient's medication related problem and healthcare related needs. So, would you assess this student at observe only, direct supervision, reactive supervision, or intermittent supervision as they're going to on this EPA for giving a flu shot? You can talk at your table too if you need to. Where do you think they kind of land? Any thoughts? Yeah. Reactive? Okay. Any other reactive as well? Direct? Okay. Okay, yeah. So we also kind of evaluated that as a direct supervision. They might be at more of a reactive. Well, we kind of have right answers in these situations. We also know that when you're in those situations on rotations, there's not necessarily a right or wrong on this. This is going to be your assessment as the preceptor. We really thought because the student doesn't need the preceptor, doesn't need to watch the preceptor give the immunization or anything like that. They're not really observe only, but they do require the preceptor to be standing kind of right next to them, watching things. And so that's where we really came up with that direct supervision. They can't be in the pharmacy somewhere across the store or anything like that. They really do need to be near them when they are administering the immunization. So then kind of transitioning to one of our required APPEs, you might be precepting a student in their hospital or health system APPE rotation. And so this student, the preceptor feels confident having them confirm the calculations and complete the initial verification of any sterile products. And then the preceptor is completing that second verification right after they do so. The student is able to complete medication histories of admitted patients independently and really only needs the preceptor oversight when they have any questions. And then prior to contacting a preceptor or a provider with a question or a recommendation, they really need to run that past their preceptor before they're able to make that recommendation on their own. So we're specifically looking at the EPA of performing the technical, administrative, and supporting operations of a pharmacy practice site. So would this student be rated as observe only, direct supervision, intermittent supervision, or reactive supervision or intermittent supervision? So you guys can take a minute and chat at your table. Where do you think this student lands? Or how would you evaluate the student as a preceptor? Yeah. Intermittent. Okay, so kind of in between the reactive or intermittent supervision. Yeah, so obviously this isn't observe only because the student is able to actually do some of those activities. They don't need to watch their preceptors, so not really appropriate for observe only. And based on the tasks they're completing, some of them are more independent and some of them are more observed. So this is where you kind of get that in between reactive and intermittent. And this might be as a preceptor, you have some other context with that student to really be able to break that tie of the reactive versus intermittent. We really thought it was more of that intermittent because the sterile products skills, they're able to do that technical aspect, but they're getting immediate feedback because the preceptor is standing right next to them doing that second verification. So if there's any issues, they're directly getting that feedback next to them. So it's right away. It's not they're doing the task and then the preceptor can check it like an hour or so later, for example. But they are doing some of those other skills like medication histories and some of those things, which would be more of the intermittent supervision. So this is where having more information about your learner and having those daily interactions, you really would be able to kind of determine which way it would fall for you. Okay, so the next one is elective IPPEs. And this is the one where we kind of tend to get more questions from preceptors, not really sure of what to do in some of these situations. So this is your student who is on their third week of their critical care elective APPE rotation. So the student is able to collect relevant information from the medical record and make accurate assessments with minimal direction from the preceptor. They also demonstrate a solid knowledge base on critical care topics, but still require some guidance on creating those drug therapy plans for the patient. And then when they are on rounds, they're integrated well in the medical team. They're able to have great one-on-one conversations with the team members, but really in that large group setting on rounds, they're very quiet and more reserved. So if we specifically look at the EPA of contributing patient-specific medication related expertise as part of the interprofessional team, do we see the student being more at the observe only, the direct supervision, reactive supervision, or intermittent supervision? What do you guys kind of think this student would be evaluated at? Any thoughts? Reactive? Okay. Yeah, so this is one where being in a critical care setting, we recognize that because this is more of a specialized area of practice, students might not get as much autonomy or have as much trust in those patient care settings. So obviously, because the student is able to participate, they're not really in that observe only. They're not watching their preceptor make the recommendations. They're involved and actively participating. But because they are kind of more reserved in that larger group setting, we really thought this would fit better with a direct supervision. They're kind of needing the prompting from their preceptor. They're doing a little bit more of that. They are doing more of that reactive supervision, maybe in that one-on-one interaction. But in the larger group setting, they're not always contributing. This is where having that feedback to that learner of saying, okay, we see you at that direct supervision right now, but let's work to get to that reactive. So let's speak up more in rounds? How can you get to that by the end of the rotation? Especially since we're kind of at midpoint of this rotation, for example. One of the other things that we see is sometimes in those specialty areas, so on electives in particular, we do see students who might on some of those required core rotations be at the intermittent supervision, might be at those higher levels, but in those specialty areas might go down a level in the entrustment. And that's where, again, it's not linear, as it was previously mentioned. We don't see students always achieving a level and then staying there. Sometimes, if they're getting into those more specialized areas, they might drop down because they're still gaining that experience and they might not be able to do it. The example that I always hear is like a NICU setting. Well, students are not going to be doing a lot of things in a NICU that the pharmacist is going to have to do. And that's okay. That's something that we kind of expect to see with our learners, especially in some of those electives. So staying on the elective, looking at a non-patient care rotation, so an admin or a leadership appy. And this is a little bit different because we don't have that direct patient care component for our learners. So how do we still evaluate those EPAs? So this is our student who's on the final week of their admin or leadership appy rotation. They presented on the influenza vaccine campaign preparations at the manager's meeting after receiving feedback of a draft that they had submitted to their preceptor previously. They shadowed their preceptor when they did an interview for a pharmacist position. And then by the end of the rotation, they were leading the daily pharmacist huddles with minimal input from the preceptor for answering questions and providing guidance on that huddle. So looking at the EPA, deliver medication or health-related education to health professionals or the public, do we see the student being evaluated as observe only, direct supervision, reactive supervision, or intermittent supervision? Any thoughts? Mhm. Yeah, so we see the pharmacist interview component of it probably being more observe only, right? They didn't really participate in the interview. So that would kind of fall into the technical aspects of the job. So that's really where that observe only would kind of fall in for that one, for that EPA. When we look at some of this delivering that medication or health related education, this is where we really see the information maybe on the influenza vaccine campaign, that they were able to do it kind of independently. They got some feedback kind of intermittently. They didn't really need the preceptor to jump in. They just submitted a draft and then were able to give feedback. Kind of similarly, we could look at those daily huddles where they're delivering that medication related information to maybe the pharmacy team. And they're not really needing a lot of assistance from their preceptor, those types of things. So we kind of would have thought this was more of that intermittent supervision as well, of when we specifically look at their ability to deliver that health related information or anything like that. That's somewhat more independent. So the intermittent supervision, but kind of what you were saying of it, the three bullets all are kind of different levels. And so that's where those EPAs might fit to different tasks that they're doing on a rotation. So just to kind of wrap up, this is kind of that new mindset thinking of how we're evaluating a student. It's not necessarily they should get an A on this rotation, they should pass this rotation, whatever it might be. This is more thinking of a progression of the student and thinking how are they evolving as a learner and growing in their trust to complete different EPAs and skills. As previously mentioned, if the schools have not already incorporated it, they will be. So you will be seeing these terms more and more on rotations and rubrics and evaluations for learners. Um, and these concepts apply to all learners. So we obviously are very focused on student experiences based on what we do, but these can apply to residents. These can apply to even your new graduates in a direct career setting or in a fellowship setting. But it also can apply to the real world setting. As Sarah showed, she can apply this with her daughter when she's cooking food. So this is something that is applicable across professions. We do see that this is utilized by other healthcare professions in other disciplines as well. They use EPAs and the entrustment scale as well. So this is not unique to pharmacy by any means. And the level of trust will vary for your learner. So it's gonna be something that's fluid. There's no necessarily right or wrong answer. It's based on what skills they come into the rotation with, what they've done previously, what rotation you have, and kind of where you see the student really being at the time that you're doing that evaluation. We generally hope to see a progression of our students from IPPEs to APPEs to practice, from that observe only up to general direction, but it's not a linear growth by any means. So, and with that, we'll take any questions that you guys have. Yes.
With the student benefit research to know, given a specific EPA, right? Let's say monitoring care plan and safety, that they continually have the right level of intervention EPA. So that the next cycle they can help them develop. Where's their thoughts on that? As opposed to becoming, you're done with this rotation with the call package, but the next cycle doesn't seem.
Yeah. So how do you know that progression when the schools kind of sees it on our end, but you don't necessarily see it between rotations? And so that's something that we're looking at is we kind of see that. And one of the things, at least from the MCW side, and I can let Concordia speak to what they do. One of the things is we also look at that progression from midpoint to final. So we're also hoping to see either they're growing, maybe they haven't gotten out of that category, but they have grown within that entrustable category that you kind of put them in. So our big concern is when we see that regression within a rotation. So we don't want to see them going from direct supervision to observe only from midpoint to final. We really want to see that growth, and it might be more of a stable growth, but we also don't want to see the regression. I don't know if do you guys have anything to add? Okay.
We're being recorded. We have been talking.
Yeah, it's like I got to get my talk show host on. So I agree. We do as well. I think that is a good. But one thing to keep in mind is it isn't, as we kind of tried to highlight with some of those examples, it may not be linear and it's not supposed to be linear. Like if a student can perform really well on core rotations, that's important. And they need to be at that at least reactive supervision to be considered competent and to pass that rotation and to be successful. But if they're put in a really challenging rotation in block 3 or 4, maybe they do slide back, and that is okay. I think we coach our preceptors to really evaluate them where they're at that moment in time, to be objective with the scale, to really give them that immediate feedback. And they may, start out a little, they might be up here for other rotations and may jump back and forth a little bit on that entrustment scale. As you put them in more complex situations, maybe they were at a small community hospital that was really, that had 100 beds and was very manageable. And then they get thrown into a large 700-bed academic medical center, that's a learning curve for them. And so we do expect there to be some movement back and forth on that entrustment scale as they move from rotation to rotation. And as a school, we are monitoring to make sure that they're at least meeting competency. But if they have those skills, I think learning to and adapting and applying them in different settings is really what makes precepting so fun, where you can see somebody that maybe struggling somebody that's early on in the rotation and able to full growth as well. Just
So we're happy to take other questions, but I know we are at 9:30, so I want to give everyone the CE code as well.